everyone, I am Dr. Devraj Singh Parmar, Assistant Professor of Cardiology in UNMICRC Institute. Today I am going to talk about approach to coronary bifurcation PCI. Okay. So basically side branch is considered stenosis, significant stenosis when the lesion is more than 50% or the osteum of the side branch should be more than 2 mm. So when it considered significant. Okay. So basically the bifurcation is considered true bifurcation and the non-true bifurcation. True bifurcation is like when the stenosis involves main and the side branch both and the stenosis should be more than 50%. Well, non-true is like it involves any of the branches, okay, either main or side branch. Okay. So basically bifurcation PCI is again divided into two. One is simple and the complex bifurcation PCI. Now the definition of complex bifurcation PCI has come from this definition study. Okay, it has both major and the minor criteria. Major criteria is like there is a distal LMC involved with the side branch of more than 70% with a lesion length of more than 10 mm. Well, in a non-LMC bifurcation, stenosis of more than 90% and the lesion length more than 10 mm is considered the major criteria. Well, in minor criteria, we include either moderate to severe calcification, multiple lesions, bifurcation angle, acute angle less than 45, main vessel reference diameter if it is less than 2.5 or if there is a thrombus or multivessel lesion length more than 25 mm. Okay. So this is a diagram that demonstrates the blood flow in a normal arteries. Normally there is a laminar blood flow, okay, but usually what happens whenever there is a bifurcation, there will be turbulence in the blood flow and that increases the shear stress that predisposes to atherosclerosis. Okay, so the commonest site is at the site of your bifurcation. So basically it constitutes around 16 to 20% of your all the PCIs, and there is very high MACE events in a patient undergoing bifurcation PCI that corresponds to around procedural complications around 9%, and there is very high incidence of restenosis in a bifurcation PCI that corresponds to around as high as 36%. So there are wide variety of formulas, but the commonest formula to identify the diameter of the proximal vessel is Finet's formula. Finet's formula usually corresponds to the proximal diameter is equal to 2/3 of the distal plus the side branch. Okay, so this is basically determined based on the angiography or intracoronary imaging techniques as IVAS and OCTs. And you should always remember the stent diameter should always correspond to your reference vessel diameter. Okay. Now the possible location for the bifurcation lesions are the commonest sites are LAD in diagonal, LCX OM, RCA PDA and LMCA bifurcation. Now bifurcation PCI is classified based on the degree of side branch angulation and the location of your plaque burden. Okay. This is a diagram that demonstrates there are two types of your angulations. First is your Y angulation and other is T angle. Y is like if there is an acute angle less than 70 degree. So here the side Y crossing is very easier to assess, but the chance of your plaque shift is very high. But if the angle is wide more than 70 degree, here the rewiring is difficult, but the plaque burden shift is less. Okay. Now again based on the location of plaque burden, there are wide variety of classifications. Okay. First is your Medina, Moorhead, Sanborn, Lefebvre, Cepheid, Duke and Syntax. The commonest classification that we use in our day-to-day practice is Medina's classification. Basically each here there are two letters, okay, for the lesion. They're like we correspond to 0 or 1. 0 is if the stenosis is less than 50%, while 1 if the stenosis is more than 50%. Okay. So this is like in a Medina classification there are three letters. The first letter corresponds to your proximal main vessel, second letter corresponds to your proximal distal vessel, and the third letter corresponds to your side branch. And based on the stenosis, we grade it as like 110, 101 and 011. Okay. So what are the advantages of this Medina's classification? It's very easier. It's simplified, but there are certain pitfalls to this Medina's classifications. Okay. Basically, it only identifies the lesion, but it does not identify the length of the lesion. Apart from this, it does not identify the length of the LMCA before the bifurcation. It also does not take into consideration trifurcation, vessel angulation and the amount of calcification. Okay, because that determines the prognosis of the patients. There is other classification that we use, that is Moorhead classifications. Okay, so this is a diagram that demonstrates in a Moorhead classification there is prefix and suffix. In the suffix, there are 4 suffix. Okay, suffix 1 corresponds to C and SL. C corresponds to a close to bifurcation, N corresponds to non-significant side branch, S significant side branch, and large proximal segment. In a suffix 2, we consider the involvement. First letter is like either main branch involved, second is like side branch involved, and the third is both main and the side branch involved. Third corresponds to the angulation of the arteries between the main and the side branch, if there is angle less than 70 and more than 70. And the fourth corresponds to calcifications. Okay. Now, how does it helps to us? Basically, whenever we are approaching a patient of the bifurcation PCI, the first thing to identify is either is a true bifurcation or non-true bifurcation. If it's a true bifurcation, we have to identify the proximal vessel segment. It's a large segment or not. If it is a large segment involvement and if it's a complex PCI, upfront we have to go through the 2 stent strategies. Okay, and based on this, we have to identify the angulation between the main and the side branch. Okay. Now, there are certain factors that you always have to consider whenever you are approaching to a bifurcation PCI. When you are seeing a coronary angiograms, there are certain factors you always have to remember. See, first thing, either is there any LMC or non-LMC involvement, location of the plaque or carinal shift, angle between the main and the side branch, and the dynamic changes in the bifurcation anatomy. And there are certain intracoronary imaging techniques that usually helps in a patient of complex PCI to improve the prognosis and to help the better outcome of the patient. That is IVAS, FFR and OCTs. Okay. So basically, there are selection of devices and strategies. Okay. Either we go with a single or 2 stent strategies, kissing balloon, and there are latest available dedicated bifurcation stents. There is BIOS, Tennis, Access and Tritone that helps to rewire the side branches. Okay. So this diagram is very important whenever you are approaching a patient with a bifurcation PCI. First thing, you have to identify the side branch that is involved is significant. Like the side branch is more than 2 to 2.5 mm diameter and it is involving a large part of your territory. So in a bifurcation PCI, you divide into 2. One is simple and complex. Simple is like in a simple bifurcation, upfront, the first technique we usually prefer is your provisional stenting. So basically in a provisional stenting, what you do is like you wire main and side branch, you put a stent in the main branch and then you do a pot and then you do a coronary angiography and see that is there any involvement of your side branch still significant stenosis or not. After provisional stenting, if the side branch is still significant stenosis, then you do a kissing balloon. You perform a kissing balloon, post dilate and then again you see. Okay. And if still, even after the kissing balloon, if there is a less than TME3 flow or side branch significant dissection or persistent side branch more than 90% stenosis, here you have to convert this provisional stenting into either T or TAP stenting. Okay. And in a complex PCI, complex bifurcation PCI, as we already discussed, here the upfront you have to undergo a 2 stent strategies, either DK crush, Culotte, mini crush techniques. Okay. So now, when should we consider the side branch as a significant and undergo a provisional strategy? So there are large number of criteria. So there are certain trials that has undergone to identify when should we consider the side branch as significant. Okay. So based on serious bifurcation trial, if the side branch is more than 50%, less than TME3 flow, or if there is a TME less than TME0 flow, even after your post ballooning dilatations, or if the LMC is more than 75% stenosis or side branch stenosis. Okay. And now based on the IVAS, okay, if the small branch minimal diameter is less than 50% as compared to your reference diameter, we should consider significant, or FFR less than 0.75. Okay. So this is a diagram that show that if the side branch stenosis is more than 90%, usually the FFR will be less than 0.75 and we should consider it a significant side branch stenosis and we should plan the revasculation of the even side branch. Okay. Now, this is a diagram that shows techniques for the stenting of your bifurcation lesion. Either in a simple bifurcation, that's provisional stenting. Provisional stenting, if failed, then we should consider T or TAP stenting. Okay. Now, in an elective, in a complex bifurcation PCI, we should go ahead with upfront 2 stent strategies. That includes either Culotte, mini-crush, decay crush or V-stenting. Okay. Now what is the guiding catheter that we should use in a bifurcation PCI? Usually in a provisional stenting, 6 French catheter is fine, okay, it takes care. But if upfront we are going to the 2 stent strategies, either we should take around 7 or 8 French catheter, that helps. Okay. Now provisional stenting. Now what are the steps in a provisional stenting? So when you are doing provisional stenting, first thing is that you put a wire in your main and side branch, then predilate main and side branch, then you put a stent in your main branch, and then you do a pot and then see the flow in the side branch. If the flow is good, well and fine. If not, then you have to do a kissing balloon, pot, and finally take a angiograms. Okay. Now what are the advantages? Advantages like provisional stenting is easiest and simplest. Disadvantages, risk of side branch occlusion here is very high, okay, and sometimes rewiring side branch is difficult, okay. It is usually best suitable for non-true bifurcation lesions, okay. Now other thing is, now whenever you are rewiring a side branch, it is very important you go to the distal crossing, because as you can see here that whenever you cross the wire through the proximal segment, there is very high chance that your stels will get deformed. Okay, and when you cross to the distal distalmost part of your struts, okay, there is a proper angulation and you can get a means better outcomes. Okay. Now there are certain problems. It's very important to do a pot, because usually what happens whenever if proper pot is not done, the wire can usually go between your stent struts and the vessel wall. Okay, so it's very important to do a proper pot and then rewire the side branches. Okay. Now there are certain tips also that helps to rewire your side branches. That is like, first thing is, as you can see here, first thing is to advance the wire distally in the main branch and then hook the ostrum, that is carinal angle of your side branch, and then with the help of this knuckling of the wire, you distally pass to your side branch. Now there is one usually reverse wire technique also. Usually here what we do is like, you take a long wire, you pass to the main wire, and then you hook the ostrum of your side branch, and then through the reverse wire technique you go to your side branch. Okay. Now there are certain catheters, that is dual lumen catheters, that are available that helps and simplifies to rewire your side branches. That is like twin pass dual lumen catheters. Okay. Now it's very important here to pot at a specific site. So in the first diagram, as we can see here, pot should not be too proximal. See, if we perform a pot very proximally, there will be incomplete expansion of your stent. Other thing is that if the balloon has went out of your stent stent, there is very high incidence of a dissection. So basically your pot should be exactly at the angulation of your carinal angle. So immediately it should cover, first it should cover your proximal strut sets. It should be exactly proximal to your carina. Okay, so there will be well expansion of your stent struts. Okay, and it's not be even distally to the like carina, because it will cause deformity in your like carinal angulation, and it will increase the high chance of your ISR or side branch occlusion. Okay, so this is a diagram that show. Now always we should remember, whenever you are taking a stent, okay, the stent should be exactly, the reference diameter should be your distal vessel, because what happens is like, so as you can see here, if you have taken the stent size of larger than the distal vessel diameter, there is very high incidence of the carinal shift, and that will cause increase in the chance of your side branch occlusion. And if you have taken the perfect size, so what happens, like initially there will be carinal shift, but when you perform a pot, then usually what happens, the side branch usually gets opened up. Okay. Now there is what is the role of final kissing balloon intervention in your provisional stenting? So basically what happens, there are a large number of trials, okay, that has shown that, okay, as such there is no more benefit in the final kissing balloon intervention in your provisional stenting. There is one even negative trial, there is Corbis 1 trial, that has shown that whenever in a bifurcation lesions, the upfront in a kissing balloon versus without kissing balloon it was done, there was a high incidence of dissection and the target lesion revascularization in a patient of like kissing balloon intervention techniques. Okay, but as such the mortality was not different between both of them. Okay, so there is no proven rule. Then one other trial has come, there is CIT resolve trial. That is basically either it has compared gel balloon technique versus gel wire technique. Here they have shown that okay, if we keep a gel balloon, okay, that has shown the side branch occlusion was significantly lower in a patient of say gel balloon versus gel wire. Okay, so what is your conventional gel balloon technique? Basically what you do is like it's same of this provisional stenting. You wire, you put a stent in your main branch, you keep the uninflated balloon in your side branch. After once you have like put a stent in your main branch like main vessels, and then you see if the flow is there in your side branch or not. If there is no flow, then you can inflate the uninflated balloon in your side branch. But the major deformity is like it will cause deformation of your stent in the main branch. So there has come like modified gel balloon technique. It is also the same in a provision setting. First you put a stent in your main vessels, and then the uninflated balloon is usually pushed in the side branch. You keep the uninflated balloon at the ostium of your side branch, and after provisional stenting, if there is a no flow in your side branch, usually you inflate the balloon of your side branch. And then but the proximal part of your balloon should be exactly at the ostium of your side branch. It does not come in the main vessel, so there will be no stent deformation. There is one other technique also, inverted crush technique. Basically what happens, that gel wire, you put a balloon, large balloon over the gel wire, and then you inflate it. But again it has certain negative points, like this your main vessel stent will get deformed. So basically in a provisional stenting, there are two. If the provisional stenting fails even after the kissing balloon, you have to go with the T-stenting or your T techniques. Okay. So basically what is your T-stenting? It's like same. We already know that okay, you have put a stent in your main vessels. Even after kissing balloon, there is a decrease in the blood flow less than TME3 flow, significant dissection in your side branch. So there is less flow. So what you do is like you rewire your side branch. First you open up the struts, and then you put a stent exactly at the ostium of your side branch. Okay, and then you do a kissing balloon and final port in T technique. Now there is other technique like tap technique. As we can see here, in a tap technique, again it's the same like provisional stenting. You first you put a stent in your main vessels, you rewire your side branch. Here the only difference is like you little bit around 1 to 2 mm you pull back your stent of the side branch little bit into the main vessels, and then final you do a kissing balloon port. Okay. So both of them, T and tap techniques, are usually best suitable if there is an angle, wide angle more than 60 degree, small. Here the side branch should be small side branch and the large main branch. Okay, so advantage is like it's basically a bailout technique in a provisional stenting, easiest technique for the simultaneous advancement of the two stents. Disadvantage is like difficult to precise, because what happens exactly putting the stent at the ostium of the side branch is very difficult, because sometimes what happens, even a small space if it is left, there is very high incidence of stent thrombosis and the ISR. Okay, so it's usually best suitable for B2T lesions. Okay. Now, as we already know that in a bifurcation PCI, if there is a complex bifurcation lesion, so upfront you have to go through your two stent strategies, and the first strategy, that is like Culotte technique. Basically in a Culotte technique you use two stents, and that leads to the full covering of your bifurcation lesions. Okay. The Nordic complex already has shown there is, as such, this was a large group of studies where they have shown that as such there was no significant differences between your Culotte or decay crush. Now what are the steps in your Culotte technique? So what you do is like first you put a wire in your main and the side branch, predilate main and the side branch. First you put a stent in your side branch, the side branch stent should be at least 2 or 4 mm in the 4 to 6 mm in your main vessel, sufficient amount for the pot. okay. And then what you do is like, and then you rewire your main branch, you put a stent in your main branch, do a kissing balloon and final pot, okay. So these are the steps that are shown. And the best thing about Culotte is like the Culotte even you can do with the 6 French catheters, okay. So what are the advantages? Advantages like it can be used as a bailout technique if the side and main branch are of similar size. It gives the best coverage of your carina, suitable for all angles of your bifurcation, and provide the best coverage of your side branch ostium, okay. Disadvantage is like rewiring the side branch is sometimes very difficult. It is basically best suitable for when your main and side branch, both of them are of similar size, okay. Then other technique is your mini crush technique, okay. So as we already know, in a mini crush technique, again what you do is like you put a wire in your main and side branch. First thing is that you put a stent in your side branch. The side branch stent should be at least 2 to 4 mm into the main vessels. You keep that you keep the other stent in the main vessels. First you deploy your side branch stent and then you deploy your main branch stent. Then you rewire your main and the side branch. Then you do a kissing balloon and then pot. So basically what is the word mini crush, why it has come? So basically in the mini crush the basic concept was to decrease the metal in your main vessel, so that okay, as when the metal was decreased in the main vessel, there is a decrease in the chance of your thrombosis, okay. So this was the 3 techniques. One is classic crush, mini crush and nano crush. The difference between them is in a classic crush we already know your side branch stent comes around 4 to 5 mm in your main vessels. Mini crush 2 to 3 mm and nano crush around 0.5 to 1 mm, okay. So we already discussed this like rewiring through the rewiring is very important in side branch, and usually you should rewire through your distal struts to prevent the deformation of the stents, okay. And the final is your decay crush technique, okay. So basically in a decay crush technique, what are the steps? So first is like, first you wire your main and the side branch, pre-dilate main and the side branch. You take you put a stent in your side branch. You keep the uninflated balloon in your main branch. Once you have kept the stent in your side branch, around 2 to 3 mm it should come in your main branch. Then you dilate it. Then you do a balloon dilatation in your main vessel so that your stents get crushed, okay. And then what you do is like, then you have to rewire your leg side branch, and then you put a stent in your main branch, and then your first thing is first kissing balloon is done in the main. That first kissing balloon should be done just before the stenting, okay. And then you rewire your main branch, and then again you have to then you do your second kissing, okay, second kissing pot, okay. So basically in a double kiss, so basically in a decay crush you do like 2-time kissing, balloon kissing dilatations, okay. So the main advantage of a decay crush over single crush is ability to rewire side branch, okay, through 3 stent layers. This was successful in 100% in decay crush, while 75 to 90% in classic crush. So however, this was successful in 98% of your mini crush studies and 100% of your nano crush studies. So decay crush makes you rewire twice instead of once with a single crush, but rewiring is more likely to be successful, okay. So what are the advantages? Basically it's easy to perform in most bifurcation lesions. Ostial side branch cover is guaranteed. There are certain disadvantages like difficulty for rewiring side branch in a final kissing balloon in angioplasty, high risk of stent thrombosis, and requires a larger catheter size, okay. Now what is the importance of your rewiring and final kissing balloon inflation? See what happens if you're unable to rewire. There is very high risk of MI and target lesion revascularization. Without final kissing balloon inflation, side branch stent is usually distorted, irregular or underexpanded. So it leads to the increased risk of your MI. So inability to rewire leads to 25% of in classic crush. So in cactus with classic crush, inability to do final crush cause MI in 7.29 versus 7.5%, while TLR was 13%. So it's significant higher. And your final technique is your V technique. So basically in a V technique, what you do is like, first you wire your main and the side branch, pre-dilate, then you put a stent in your main and simultaneous stent should be placed in main and the side branch, and then you do not lose the access, and then you do post ballooning dilatation, kissing balloon and the pot. So basic advantage is like you never lose the access, but the only thing is that simultaneously passing the stents and post ballooning dilatation is more often difficult. Okay, so both stents are pulled back to create a new carina as close as possible to the original stents. Okay, so the advantage is like the operator will never lose the access when the final casing balloon inflation is performed, but the disadvantage is like positioning of the stent proximal to the double barrette is very problematic. So it results in the bias towards one of the two branches and will leave a gap between both of them. Okay, so there are certain landmark trials that have shown that okay, the upfront two stent strategy is better than the provisional stenting. First is like cross Korean trial and Nordic 3 trial. There is like either provisional stenting or leave it alone. So it has shown that okay, the provisional stenting is better than the leaving it alone. Then upfront two stent strategies like perfect Korean trial, there is in most of them it was done with a decay crush, okay, versus provisional stenting. It has shown that okay, two stent strategy is better. Nordic 4 was for the Culotte, EBC 2 was for the Culotte, and decay crush 2 was for the non-LMCA. It was performed with the like decay crush techniques. Okay, and in the left main LMCA involvement, EBC main, decay crush 5 and Excel analysis, that has shown that okay, the upfront two stent strategies was found better than the provisional stenting. So basically bifurcation lesion recommendations. So the commonest classification that we should use in a bifurcation technique is your Medina's classification. Provisional stenting approach is recommended in most bifurcation lesions. POT should be properly done. If you are going ahead with the two stent strategies, lesion preparation is very important. Okay, and there should be low threshold for intracoronary imaging techniques. Okay, so what are the take home messages for the bifurcation PCIs? So first is like whenever you are doing balloon or stent expansion in your distal main vessel, the size of the stent should always be determined based on your distal vessel diameters. Then POT should be of sufficient of. Each time a stent is deployed in sideband, rewiring and final kissing balloon is mandatory. Okay, this sequence is often used after any stenting in bifurcation. POT, first is POT, rewire, kissing and report. Okay, and now whenever you're doing a kissing balloon, consider sequential kisses, high pressure in each branch followed by simultaneous kissing at 12 atmospheric pressure. Thank you.